Silver Cross family. Welcome to the Community Lecture Series. Today, it's all about fibroids. I'm Dr. Gamillah Pierre from Partners in Obstetrics and Women's Health here at Silver Cross.
I'm Dr. Ashish Vyas. I'm an interventional radiologist with Advanced Midwest Radiology here at Silver Cross Hospital.
I've also brought along Angela Cobianco, a medical assistant from my practice, to help us with fibroid FAQ. Let's start with a fictional patient, although this is a typical patient in my office. Finally, now that COVID has relaxed, Miss Elaine Williams makes an appointment in the office. She's complaining of heavy menstrual bleeding and increasing abdominal size despite vigorous exercise. After gathering Elaine's history and performing a physical exam, I suspect Elaine may have fibroids. There are several ways to diagnose fibroids, including pelvic exam, hysteroscopy, which is a camera placed into the uterus, ultrasound, and MRI. In order to confirm my suspicion, I recommend a pelvic ultrasound. Dr. Vyas, can you explain what Elaine is likely to experience?
Sure. Pelvic ultrasound is a great screening tool for a lot of different GYN complaints, such as pelvic pain, bleeding. And pelvic ultrasound is done as an outpatient. We bring the patient in, and usually there's two types of ultrasound that's performed. One is a transabdominal ultrasound, which is a ultrasound probe. If this was the probe, it'd just be on the skin to look at the pelvis directly. And then there's a transvaginal sonogram, which is where you place a probe through the vagina, and we would like our patients to have their bladder full. And with the bladder full, you're able to see through the bladder and into the uterus and see such structures as the endometrial cavity, and then evaluate for the possibility of fibroids. And it's a great screening tool for patients who are suspected to have fibroid disease.
My suspicion has been confirmed, and Angela calls Ms. Williams with an update and requests that she schedule a follow-up appointment in the office. Elaine is nervous and asks Angela many good questions. Angela, what are some of those questions?
Most patients' first question is, what are fibroids?
Recognizing Elaine's concern, I phoned her to explain that fibroids are non-cancerous tumors that grow in the wall of the uterus. Rarely, they can be found in other parts of the body. Fibroids are very common, occurring in approximately 60% of all women. They are considered tumors, but only rarely are they cancerous. In fact, it's less than 1%. Fibroid tumors range in size from very small, 1 centimeter, less than the size of a pea, to very large, 25 centimeters, or more like the size of a volleyball. I reassure her that we will go into more detail at her appointment, and we will discuss both non-surgical and surgical treatment options. Any other questions, Angela?
Typically, they also ask is what causes fibroids?
Actually, the cause of fibroids is complex and not well understood. We do understand some risk factors, including early age of the first period, obesity, a high-fat diet, and there's a strong familial tendency. There is a relationship between estrogen, however, it's a complex relationship and also not well understood. Once Elaine returns to the office, we review her ultrasound as well as her other symptoms: pelvic pain and pressure, abdominal protrusion, heavy and abnormal bleeding, and bowel and bladder dysfunction, such as constipation and urinary frequency are common. Some cases, they may even cause infertility or miscarriage. At this time, we decide to discuss with Elaine what her treatment options are. And we have many treatment options which range from surgical to non-surgical to non-invasive procedures. Not all fibroids actually require treatment. If a patient does not feel their symptoms are debilitating, they may opt for conservative management or a watch-and-see approach. However, fibroids causing daily disruption in their daily activities may require treatment. We often use hormonal management, such as birth control pills, to treat the bleeding symptoms, but honestly, there's no great medication which reliably or permanently decrease the size of the fibroids. As far as surgical options, gynecologists are able to surgically remove the fibroids. That's known as a myomectomy. Myomectomy spares the uterus. Large fibroids may actually require an abdominal incision, which is similar to a C-section scar. But most myomectomies can be performed through small incisions. These are minimally invasive techniques, and they include vaginal approach, hysteroscopic approach, laparoscopic approach, or robotic approach. Some patients will ultimately desire the complete removal of the uterus, also known as a hysterectomy. Perhaps the patient has completed childbearing and has had other surgeries in the past and wishes to proceed with definitive treatment. Hysterectomies are performed also through minimally invasive techniques, either through the vagina or through small incisions, such as the laparoscopic approach or the robotic approach. Now let's talk about some non-invasive techniques to treat uterine fibroids.
So in regards to non-invasive techniques, there's a procedure called uterine fibroid embolization, which is a non-invasive procedure done by an interventional radiologist like myself. It's an outpatient procedure. It's primarily performed for patients who don't wish to have their uterus removed, or in other circumstances where certain GYN procedures have failed or the fibroids come back. This is an excellent treatment option for patients who have primarily heavy bleeding or bulk symptoms. Bulk symptoms meaning pelvic pressure, pelvic pain, increased abdominal girth from the actual size of the fibroids themselves. And we do this as an outpatient. We see our patients in clinic. Usually we get referrals from Dr. Pierre or her colleagues. And we do a thorough H&P in the office. We see them, all of our patients in clinic. And besides the pelvic ultrasound that we talked about before, there's one other big piece of information that's helpful for us prior to considering a uterine fibroid embolization, and that is a pelvic MRI. And that MRI provides a lot of information in terms of the size of these fibroids, the location of the fibroids, and the really big part of the physiology of the fibroids, which is their blood supply. If you can imagine that patients who are often bleeding from fibroids, have heavy periods, you can imagine that these fibroids are benign tumors again, but they have a large blood supply. And if they have a large blood supply, that means that they can be treated through this procedure called UFE. And so what does embolization mean? Embolization is a word that describes stopping or slowing blood flow to a specific organ, to a tumor, or to a specific site. And it's very targeted therapy. And so uterine fibroid we already talked about, so we're talking about slowing the blood flow or stopping the blood flow to these fibroids so that they can eventually decrease in size and stop bleeding for all these patients.
Excuse me, Dr. Vyas. This sounds as if this could be painful. Is this painful?
So the procedure itself is not very painful. The actual procedure takes about 90 minutes. It's usually done through a paper cut incision right on the skin. Usually in the groin region is where we get access in the artery, or in the wrist as well, depending on the anatomy. But we have like some props here that I can show you, but the access site is really just small enough to have a small catheter into the artery, and then we get into the arteries that supply the uterus using X-ray and a little bit of contrast dye, and the entire procedure takes about 90 minutes to complete. There's a left uterine artery, there's a right uterine artery, as you can see on this picture here on the slide, where you can actually see that there's a small little syringe on the right side of the picture, and then the arteries are supplied to the uterus. And we get selectively into those arteries using a small catheter like I just showed you here. On the slide here is an MRI of the pelvis, and just to kind of reiterate, on the left this is the uterus in what we call like kind of an sagittal plane, where you can see the uterus from the side, and you can see these dark areas. Now when you give contrast, they light up like light bulbs, and that's kind of what we're looking for to see when we treat them. Now in regards to the question about pain, is it a painful procedure? The procedure itself is actually not that painful. Really the worst part of the procedure itself is a little poke and a burn on the skin from some lidocaine. And then after that, the skin is nice and numb, you place a small needle into the artery using ultrasound, and then a little push at the side where the access site is, and then the procedure is started. Takes about 90 minutes to do, roughly. Now, the procedure itself is not painful, but afterwards, yes, there is pain. So while the procedure is not entirely painful, there is expected pain, which we know about, and that is essentially described as really bad pelvic cramps. Some people describe it as mild, kind of what they're used to in their normal cycle, to quite painful, where it's the worst cramping of their life, as some people say. That being said, I explain that to every one of my patients, as I'm sure Dr. Pierre does, is that we expect this pain to be present, we expect it to be variable depending on the patient, but it's our job to keep you comfortable and make sure that your pain is controlled, which is why we keep you overnight for the procedure, just afterwards, for one evening. And that's primarily for pain control.
My patients want to know, will they be able to have a baby after this?
Yes, so that's a great question. That's a very common question to ask. People get confused with this procedure. Does it cause infertility? Does it not cause infertility? To date, there's no data that suggests that it causes infertility. It's very important to keep in mind that we're treating the uterus and not the ovaries. The ovaries are responsible for delivering the egg into the uterine and then into the endometrial cavity. We're treating specifically the uterus. So in some cases, and this is kind of anecdotal in some ways, but also there's some evidence to suggest that if you treat the fibroids and make them smaller, you might give them the egg an opportunity to implant into the endometrial cavity more successfully. And what I can tell you is that obviously a hysterectomy is no way to have a baby after a hysterectomy,
No.
unfortunately. So this is a great option for folks who really want to, either have an opportunity to have children down the road, if they haven't decided to do that yet, or if they're having trouble. In addition to patients who want a non-surgical option.
Very good, thank you. Angela, anything else you think Ms. Elaine has been asking us about?
I think another question is what's the likelihood of fibroids coming back after?
That's a good question. So depending on how fibroids are treated, there is always a possibility for recurrence. The only possibility for no recurrence is a hysterectomy. That completely removes the possibility that fibroids will come back in the uterus because the uterus has been removed. A myomectomy, which does spare the uterus, is meant to debulk or to remove certain of the fibroids, sometimes all, sometimes some, sometimes only one or two, depending on the patient's clinical situation. But those fibroids or new fibroids can regrow. Since we don't understand the complete origin of fibroids, we do understand that by leaving the uterus behind, that there is an opportunity for the remaining fibroids to continue to grow or for new fibroids to arise. How about with the embolization procedure?
That's a great question. So for treatment of bleeding in particular, UFE has a very high success rate for stopping or controlling bleeding. It has a greater than 95% success rate for the treatment of stopping heavy periods. And as long as the blood supply is treated in such a fashion that, if you look on this slide here, where you can see this x-ray image where there's a large fibroid here that's, after you inject some of that contrast dye, you see that fibroid light up like a light bulb. Once you close that blood supply down to those fibroids, there's a very low recurrence of symptoms. Now, the fibroids themselves ideally will shrink down with the procedure, as they do when you treat them. Recurrence rate is lower in terms of their symptoms, in terms of bleeding. Can they come back? The answer is yes. There's always a possibility. My personal experience, for the purpose of treating bleeding and bulk symptoms, that frequency is very, very low. And so typically what we like to do is get a pelvic MRI in the beginning before the procedure, and then get one at 6 months to see exactly how these fibroids have responded. And the vast, vast majority of cases, the fibroids have shrunk and the clinical symptoms have improved really within 2 to 3 menstrual cycles. People can see, especially when it comes to bleeding, that people have really good response quickly.
Great, thank you. Well, probably answered most of her questions. And you may be wondering what she's going to decide. But as we can see, she has several options, all the way from doing nothing to a non-invasive procedure to complete removal of the uterus. Each individual patient needs to be assessed with their physician to make the decision which is best for them. So we can't tell you what Elaine decided, but we can say that we have come to the conclusion of fixing fibroids. So I'd like to thank Angela, Dr. Vyas, for the opportunity to discuss with you some fibroid FAQs.
Thank you.
Thank you.